So if a pre-diabetic, diabetic, and non-diabetic, the mortality steeply increases. Dysglycemia is a strong independent risk factor for heart failure hospitalizations as well, increasing the risk of hospitalization by 50%. And poor prognosis of HEPF and HEPREP with diabetes occurs in men as well as women. The blue bars are diabetic people. This is survival on the y-axis. So survival of diabetics, blue bars, is much less than the gray bars, which are non-diabetic individuals in men and women. Is prognosis of HEPREP different in Indian patients? Beautiful study done by Seth et al. In 2015 showed that the mean age of HEPREP patients across the globe is 73 years. India, it is 53 years. In hospital mortality with the first episode of congestive heart failure across the globe is 4%, and in India it is 30%. So we have a lot of work to do in HEPREP patients in guideline recommended therapy. Where did we go wrong then in treating the diabetes? Did we go wrong anywhere? Of course we went wrong, because we were glucose centric. We had an irrational belief that lowering blood sugar by virtually any pharmacological means will produce reliable reduction in adverse outcomes. Well, did that happen? No. The drugs produce hypoglycemia. Glitazones-like drugs produce fluid retention. Some drugs increase LDL. Some drugs cause weight gain. And some drugs cause increase in the blood pressure, like some DPP-4 inhibitors. All these cause negated the effects of hypoglycemia or euglycemic control in diabetes. So weight gain is a bad news in diabetic heart failure. Very bad news in diabetic heart failure. So I suggest that every patient of heart failure, if he's overweight, the first thing that he should do is to control the weight. Intensive glycemic control in many trials of CVOT trials of diabetic drugs like Accord, Advance, UKPDS, ATS did not show any significant benefit by excellent diabetic control on heart failure outcomes. As did they show in MACE outcomes. So heart failure and diabetes, one of the most common cardiovascular manifestations, most disabling, very high rates of subclinical heart failure and dysfunction, and very high mortality over follow-up. Therefore, Eugene Brunwald, the father of cardiology, said that surely the time has come for cardiologists to learn more about diabetes and diabetologists to learn more about cardiology. So we should have a better branch called cardiodiabetology or diabetocardiology. As cardiologists, what do we expect from oral anti-diabetic agent? I want an agent to be cardio safe. That is my first minimum requirement. It should not damage my heart. It should not increase MACE. It should not increase heart attacks. It should not cause fluid retention. It should not cause heart failure. It should have pleiotropic benefits. It should produce weight reduction. And if not, at least it should be low weight neutral. It should be potent. It should give a potent and durable glycemic control. And it should have robust evidence base. Do we have then drugs to fulfill those expectations? Let's see. So we had a light at the end of a dark tunnel in the oral anti-diabetic drugs. And this light came in the form of SGLT2 inhibitors and ARNI. So effects of sacubitril valsartan in patients with heart failure and diabetes. Let us talk about that. Paradigm heart failure enrolled around 8,000 patients with HEPREP. 25% were pre-diabetic and 13% had undiagnosed diabetics, while 35% had known diabetics. And this drug caused 20% risk reduction in heart failure mortality, cardiovascular death, 19% reduction in all-cause mortality, and 22% reduction in heart failure hospitalizations. Mind you, these people were adequately treated with beta blockers, MRA, and ACE inhibitors at the outset. ACE inhibitors were withdrawn and the patients were mounted on ARNI. So, sacubitril valsartan also caused reduction in HbA1c. So, it improved the diabetic milieu of the patient. It caused 21% reduction in the new need of insulin in patients with diabetes with HEPREP. And therefore, it got added in the guidelines. So, as compared to our guideline-directed medical therapy of ACE, beta blockers, MRA, and hydrogen nitrate, we now have ARNI, which causes 20% incremental risk reduction in heart failure mortality over and above the guideline recommended proven therapy for decades. That is most important to understand. It is an add-on benefit. It is not an exclusive benefit of ACE inhibitors or ACE inhibitors. This was one big step forward. And the next big step forward came in the terms of SGLT2 inhibitors. SGLT2 inhibitors act uniquely. They don't depend on beta cells. They don't cause exhaustion of beta cells. All they do is reduce the proximal tubular reabsorption of glucose, causing glycosuria, calorie loss, weight loss, and osmotic diuresis. Predominantly, they are insulin independent. And moreover, they cause mild persistent ketonemia, which is beta hydroxybutyric acid levels in the blood go up, which is an energy efficient super fuel, which helps the myocardium to generate more calories in addition to free fatty acids. They also cause weight gain, which we so much more want in patients with HEPREP. And moreover, the SGLT2 inhibitors cause preferential diuresis from the interstitial compartment as compared to intravascular compartment. So they don't cause contraction of plasma volume just the way diuretic cause, causing secondary activation of RAS system. They don't. So SGLT2 inhibitors act complementary to diuretics. They don't cause volume contraction. They don't cause secondary activation of RAS. So we know that we had 3 coveted trials: EMPA-REG, all patients with secondary prevention; CANVAS, 2/3 secondary prevention, 1/3 primary prevention; and DECLARE, 2/3 primary prevention and 1/3 secondary prevention. All these trials had patients with coronary artery disease, cardiovascular disease, and peripheral vascular disease. And some, of course, they had primary prevention cohort as well. Just this slide to show you that almost 25% patients in EMPA-REG and 20% patients in CANVAS trial were renally impaired patients with an eGFR of less than 60. And across the board, EMPA-REG, DECLARE, and CANVAS showed reduction in heart failure hospitalizations across the board. Primary prevention or secondary prevention, cardiovascular disease or no, peripheral vascular disease or no, they all cause consistent, significant reduction in heart failure hospitalizations. And if you look at the SGLT2 effects with ASCVD or without, that means in primary prevention group or secondary prevention group, they were also consistent. There was no factor interaction there. Also, the SGLT2 inhibitors acted despite previous history of heart failure or not. So they prevented heart failure hospitalization in patients with reduced CF without previous heart failure, or patients with reduced CF with previous clinical heart failure. And then came our coveted DAPA-HF trial. This trial, dapagliflozin was added in optimally treated patients with chronic HEPREP with ejection fraction of less than 40, with elevated natriuretic peptide and eGFR of more than 30. Look at this. These patients, 90% were on diuretics, 95% were on ACE inhibitors, almost half of them were on ACE inhibitors, and rest were on 11% were also on ARNI, and 96% were on beta blockers. 70% were on MRAs. They were really, really optimally treated patients with HEPREF. And all that was done. In addition to RAS blockade, a DAPA was added. And that showed 21 number needed to treat to prevent 1 hospitalization for 1 year. Worsening cardiovascular events and cardiovascular death was also reduced by 20%. And of course, the primary endpoint of cardiovascular death and heart failure hospitalizations significantly reduced. Whether the patients were on ARNI or not on ARNI, they were equally benefited. All-cause death, which was reduced out of SGLT2 only by EMPA-REG before, now again was reduced by DAPA. So DAPA is the only second SGLT2 inhibitors which has reduced all-cause death in patients with HEPREP next to empagliflozin. CANA has not been able to show that kind of a benefit. These all advances have caused paradigm shift in the management of HEPREP patients. DAPA now features at the top, which is reducing 17% reduction in all-cause death in patients with heart failure over the previous trials like CIBIS, Copernicus, MERIT, TRACE, AIRE, SALT, prevention and treatment, and SAVE, the old trial with captopril. Okay, then you will say, Dr. Ponde, all this is fine, but have the guidelines changed? Yes, they have. 2019 ESC guidelines clearly say that SGLT2 inhibitors should be given to patients to reduce the heart failure risk. Class 1A recommendation. Mind you, gentlemen, class 1A recommendation as an add-on therapy to adequately treated patients with HEPREP, with beta blockers, RAS inhibitors, vabradine, and MRA who remain symptomatic despite guideline recommended therapy. There are several potential reduction of albuminuria, reduction of sympathetic activity, mild ketonemia producing a superfuel, and decreased arterial stiffness. Now, as you see on the right-hand side, in addition to 3 building blocks of HEPREP, beta blockers, RAS blockers, and MRA, we now have ARNI on the right, and we have DEPA. So these are now add-ons in the treatment of heart failure. My goal in this lecture was not to take you to the path where you feel, oh, this we all know. No, my goal was to create a therapy of ideas and to try to bring in new ideas so that we can see the old same problem of HEPREP and diabetes with a different attitude and different kind of a approach, aggressive approach, because diabetic heart failure is a worse heart failure to deal with as compared to non-diabetes. Thank you for your attention.
Yeah. Thank you, Ponte sir. Wonderful. It was an excellent overview of heart failure and currently where we stand in 2020. So I think Ratnaparki sir has a comment on that, and then we can.
Shekhar, it was excellent lecture as usual.
Yes, sir.
Okay, when I listen to you, I always remember my JJ days. Okay.
Thank you.
The management of heart failure is established. There are 4 pillars, what you have already mentioned: ACE inhibitor, ARBs, beta blocker, and MRA. Over that, this new anti-diabetic regime we can add, whether patient is diabetic or non-diabetic.
Yes.
One addition, because this DAPA or this SGLT2 receptor antagonist produces hypoglycemic effect, pleomorphic effect, weight loss, diuretic-like effect, anti-inflammatory, right? These 5 mechanisms are there which will produce this cardio beneficial effects.
Yes.
To ask you, with these effects are profoundly found with liraglutide also. Liraglutide also.
Yes.
In leader tire,
yes,
same parameters are observed rather profoundly.
Yes.
If you compare liraglutide or other GLP agonist trials, there are 4 trials. The absolute benefit is almost equal with SGLT inhibitors, slightly better also. So why not to add that also in a diabetic, at least diabetic heart failure patients? This is
actually, the benefit was not benefit in heart failure was modest. The benefit on MACE was much higher. And remember that liraglutide is a parenteral drug. It is an expensive drug, and the curves very important. When you start an SGLT2 inhibitor, you know the curve starts separating as early on the 17th day. 17th day, the heart failure hospitalization risk reduces significantly within 17 days of starting an SGLT2 inhibitor. That for liraglutide to occur, the curve start diverging after 9 months of therapy, which is a very important point. So I think before we start seeing the benefits of GLP-1 receptor agonist, we have to wait fairly long. We have to give an injectable drug, an expensive drug. Yes, and the cost. So all that we have to keep in mind. Whereas SGLT2 inhibitor is a single pill. Oral. Now we have got SGLT2 inhibitors combined with a renal friendly DPP4 inhibitor like linagliptin. Okay, so all these are very big things in diabetic patients with heart failure, and I think we should think like this: that, in my opinion, DAPA, you first choice if the patient remains symptomatic despite an ACE inhibitor. The first thing is withdraw the ACE inhibitor, introduce ARNI. Many times, the ARNI produces profound blood pressure loss, and you are not able to uptitrate the ARNI, or hyperkalemia occurs, and your dose of the ARNI is restricted to 50 BD or maybe 25 BD also sometimes because of prohibitive fall in blood pressure. That time, if the patient remains symptomatic, it is worth adding DAPA. Till to date, I have treated 32 non-diabetic patients with heart failure with heprep with dapagliflozin. Only one elderly, frail patient with a 52 kg had hypoglycemia. None other non-diabetics had hypoglycemia. So I think it's a great drug to use. We have to develop confidence and treat the patients as better as we can, so that we flatten the curve and reduce the mortality at 5 years.
I think, Shekhar, one more comment in the GLP. I think Ratnaparke has raised. GLP are good drug for atherosclerosis process, but heart failure have been modest drug compared to SGLT inhibitors.
Yes.
So that has been proved. So I think as a heart failure is concerned, the first choice is SGLT. GLP has great drugs. Of course, they are one. Of course, it's sort of like injectable, and apart from that, but they are good for a pipe, filter, and pump. I think again the SGLT makes a much more better difference actually. And Shekhar, one more comment. Actually, you talked about the intensive trials, actually, Accord and all that thing. Only UKPDS has shown some benefit in the cardiovascular mortality, whether the others have not shown that much benefit, because probably they had more evidence of hypoglycemic events in intensive therapy. In that time, the drugs were available, one thing. And probably only UKPDS is a very long study, and there was some benefit. Accord, Advant, all that trials didn't show any benefit. In fact, some of them showed a harmful effect because of the more incidence of hypoglycemia where the intensive control was tried. So if you had a better drug which should not cause hypoglycemia, the outcome would have been probably different. So intensification is not bad, but I think the hypoglycemia associated was bad. The third thing I want to ask you, do angiography. How many patients of diabetic heart failure you find normal coronaries? How frequently do you get it? That's
Almost,
actually the same.
No, see, I'll tell you, almost 25% of HEPREP patients with diabetes had old myocardial infarction and loss of myocardium to reduce their EF, and finally they go into heart failure. Another 1/3 have HEPF, normal coronaries, stiff myocardium, and heart failure with near normal ejection fraction, 55% and above. And the other 1/3, around 20-25%, have typical diabetic cardiomyopathy. And this we have, in fact, our paper is, I can't disclose that a paper is almost about to get published about the MRI findings in pure diabetic cardiomyopathy. Their extracellular volume is increased, and there are deposition of glycated aminoglycans in the interstitium.
And mitochondrial level.
Yes, sir. Yes, sir.
So that is a separate entity. I think that you can't do any invasive procedure. And you have to manage only medically them actually.
Yes,
that's the
yes,
only
sir.
way.
Yes, sir.
Now even pulmonopathy of diabetic is known actually. Just come. Some people just recently publication actually.
Yes, sir.
Okay. So request him to stay back for a lot of other questions which are already been popping in. So sir, please stay on. And I'm very pleased to announce that we have almost joined by 240 plus attendees. So it is a blockbuster CMA which is going on. So I request everyone to stay on. So I'll move on to the second session. So for that we have got a chairperson in the form of Dr. Ramesh Dargad, sir. Sir again needs no introduction. Sir is a senior most physician in Andheri East, a very great academician and clinician, and has got a lot of publication and everything under his credit. And I'll ask sir to introduce our second speaker, Dr. Sudhindra Kulkarni, for the evening. Dargad, sir.
Thank you, Kapil. I think Sudhindra Kulkarni doesn't need any introduction. He has been very popular in our APPA meetings and always help us. And whenever we had need help of endocrinologist, he is associated with Fortis Hospital, Mulund. And of course, he has done his GNB endocrinology for Hinduja Hospital. But of course, he's mainly based in Andheri and he has a clinic in Andheri. So he's been more closer to us and is a member of APPA and always helping us in all our academic meets. So I will request Sudhindra Kulkarni to start his presentation today. Thank you, sir. And over to Dr. Sudhindra Kulkarni.
Yeah, and good afternoon, everyone. And thank you, Dr. Dargad, for the kind introduction. And thank you, JB Chemicals, for today's session. So after the nice talk by Dr. Ponde on heart failure and diabetes and the use of SGLTs, my turn is now to talk about hypertension in diabetes and of course the role of fixed drug therapies. So, you know, in diabetes, I'm sure you've been following the data and studies which are there. So recently there was a trial which was published called as Verify trial with vildagliptin and metformin, talking about, you know, hitting hard with, you know, fixed drug combinations at the beginning of diabetes. So similarly, I think this analogy applies to hypertension. And I think that is what we are going to see now. because hypertension is so common in diabetic patients that one needs to be on the lookout. And of course, apart from diabetes, the non-diabetic hypertensives also need to be on the right medication to reach to the targets. So let's see what the best antihypertensive combination is for the diabetic hypertensives. Next slide. So, hypertension, dyslipidemia, type 2 diabetes, these are all risk factors for the development of cardiovascular disease. And if you look at the kind of data which is there, of all the type 2 diabetics, 60% have hypertension, 60% have lipid problems, and 90% are overweight or obese. I think this is very interesting data. Hypertension was found in 82% of those with CKD, 77% of those with diabetes, 74% with peripheral arterial disease and heart failure, so on and so forth. And dyslipidemia patients, 48% had hypertension. So we can see that, hypertension is ubiquitous as far as, all of these, cardiometabolic problems are concerned. And overall, 23% of individuals without, severe comorbidities have hypertension. So it becomes a challenge. Next slide. To manage the hypertension, and combination therapy is one of the choices which is there, and most of the guidelines which are published, as you can see here, talk about combination therapy being superior to the sequential monotherapy for the initial treatment of hypertension. So put it simply that, if the patient's blood pressure is 20 millimeters above systolic or 10 millimeters above diastolic, a combination therapy would be the best thing to do in the beginning itself rather than going with a sequential monotherapy. So the outcomes are better if you
Sir, you are not audible.
I think he has.
Yeah, due to some internet glitch, I think Dr. Kulkarni has logged out. Just bear with us for 2 minutes. I think he'll rejoin again.
Can you audible now? Kulkarni sir.
Yeah, sir, he's joining. I just spoken with him. He's joining in a minute.
Otherwise,
He's disconnected.
In the meantime, I'll request all the attendees to put questions in the chat box for the speakers and also for the chairperson. So at the end of the talk, we will take all the questions together in the final discussion. So whoever have some kind of queries, they can put in the chat box. We will try to answer most of them in the time permit. Thank you.
Kapil, meanwhile, you can ask some question to Dr. Ponde sir or.
Yeah. So, Ponde sir is there?
There are some questions in the chat box. You can just
Yes,
finish
sir.
up that.
Yeah.
Ponde sir,
Yes.
are you there, sir?
Yes, I'm there.
Yeah. Okay.
Hello.
So, yeah. So there are. I think there are a couple of questions, and
Yes.
I'll go with first from, I think, Dr. Ambadekar
Yeah.
has that question.
Yeah.
In India, we in India follow American European guidelines while managing heart failure. Still, outcomes in India are much worse. So
Yes.
where did we go wrong? So can you elaborate on where we are actually going wrong in managing heart failure, and why our numbers are so bad as compared to maybe in Western population?
There are three important reasons. Can you hear me?
Yes,
Yeah,
we can hear you.
Yeah, there are three important reasons. One is that we don't start the guideline recommended therapy
Early.
before the hospital discharge. What happens is there is this peculiar kind of a thought. Oh, let the patient get stabilized. Now he has just come out of the ICU. Hypertension may occur, bradycardia may occur. So let him go home. Let him come back after a week or two. That time I'll start a beta blocker, or that time I'll start a ARNI or something like that. So guideline recommended therapy started late. Number one. Number two, when the guideline recommended therapy started, most of those titration is not done. So people are left with carvedilol 3.125 BD for a year, or ACE inhibitor 2.5 OD of ramipril for 6 months, something like that. The third important thing is that the three targets of blood pressure is start low, go slow, and keep on up titrating to a maximally tolerable dose. Most of the benefits come of ARNI when you reach the dose of 100 milligram BID, or carvedilol when you reach the minimum dose of 12.5 milligram BID, or bisoprolol 5 milligrams a day. On the top of that, please look at the heart rate of the patient. If despite maximally tolerated doses of beta blocker, if the heart rate doesn't come below 70, add ivabradine. So all these guideline recommendations, if we follow, we will reduce the mortality. And if I tell you, the recently published Asian heart failure registry, which I was a part of, we did two groups. One group was guideline recommended therapy, and second group was the standard therapy. In guideline recommended therapy, the 1 year mortality has dropped down to from a previous 18% to 8.3%. And a 3 year mortality, which was previously close to 35%, has gone down to around 19%. So please remember, guideline recommended therapy is the answer and the way to go. Thank you.
Yeah, sir.
Hello.
Another. Hello.
Kapil.
Yeah, sir. Okay. Sir, you can start from where you have actually where you were out of.
Please
so you can
please.
start, sir. Yeah, please.
Yeah. Sorry, I think there was a internet connectivity issue. So I was talking about the combination therapy for initial management of hypertension in diabetes patient. And we said that, any systolic about 20 or diastolic about 10 would warrant a combination therapy. Next slide. So all of this would be, useful in many ways, in the sense that if one is using a fixed drug combination or a single pill combination therapy, in most of the hypertensive patients, it would also be like, following the guidelines which are there, as well as the algorithms which are there, also improve the adherence of, drug therapy for these patients, because, drug discontinuation because of the pill burden, etc., remains one of the major reasons of uncontrolled diabetes in most of our patients. And I think these FDCs would help in improving the compliance and improve the outcomes. Next slide. So, does it really, matter whether you use monotherapy or increase previous slide, or you use these free FDCs? So this is one interesting study, which was actually a real-world study, which talked about the early, cardiovascular protection, which is brought about by using a 2-drug fixed dose combination compared to monotherapy in the hypertensive population. So this was a very large database study of almost 45,000 patients done from Italy. They said that the CV events were much lesser in patients who were given the two drug fixed dose combinations compared to the monotherapy. Next slide. So FDCs, as we said, have a better outcome, so greater BP reduction versus the monotherapy, heterogeneity in the BP response because of action through different mechanisms, steeper BP response relationship, hypotensive episodes may be minimized, and of course better outcomes and reducing the therapeutic inertia. Sometimes it happens that inertia from the doctor's side or the patient side always leads to uncontrolled diabetes, and of course all the reduced CV events which are seen with these two drug combinations. Next slide. So initial combinations are useful especially to meet the targets which are there. So single pill based combinations help to improve adherence, as we said, and bring about better outcomes. And of course, in the initial, monotherapy can be reserved for BP control in the high normal range or the very old patients or the frail patients where you want to be going slow and need not precipitate, hypotension in these patients. Next slide. So would a faster control of blood pressure have, a better benefit or outcome, or would it be a better strategy, to go slow, like we say in insulin therapy, start low and go slow. So would aggressive, BP lowering in the beginning itself with a combination help to bring about better clinical outcomes? Next slide. So as we said, apart from all this, the outcomes as far as, fixed drug combinations or the combination therapy is much better. Apart from, of course, the less side effects, convenience, better effect, low cost. While with the monotherapy, you need to, keep on adjusting the dose, increasing to the maximum dose, so on and so forth, and more likely to be, costlier for the patient, inconvenience, non-compliance. All of these issues would, come up. Next slide. And these all can be avoided with the use of SPCs. So use of an single pill combination was associated with 29% increase in adherence and persistence versus the same drugs which were given as separate or free drug combination. So again, I think this is a very interesting point which was presented in the ESC Congress 2018. Next slide. And unlike diabetes, where combining two medication, now that we have so many medications, which are India has always been a FDC country, but even with the newer SGLT2s, DP4 inhibitor combinations, we don't see that multiplying effect of reduction in the HbA1c. Unlike that, the BP lowering efficacy of two drugs which are combined is much better when unlike when the monotherapy escalation is done or the combination is done. So this is one interesting point, that 5 times greater BP lowering efficacy with a combination compared to the increasing monotherapy. So I think this will be again a very important point to support the use of FDCs. Next slide. So again, we can see here that the combination therapy offers better control of blood pressure, reduction in the blood pressure as compared to the monotherapy. Next slide. And the percentage of patients reaching the target also is much more, and time to achieve the optimal BP control is much faster, and that leads to reduction in the risk of CV events to the extent of 34%. So more rapid achievement of the blood pressure reduce the CV events also occurring in these patients by 34%. So I think again a point which is in favor of use of FDCs at the beginning. Next slide. So is it really important to strongly discuss if a first choice drug exists? So when we talk about our diabetic patients, we always want to use certain category of drugs, especially the RAS inhibitors or the calcium channel blockers as first line of therapy. But in this combination, I think there is advantages that one can use multiple drugs and bring about better normalization of the blood pressure. So single drug therapy can normalize blood pressure values in no more than 30% of the patients with grade 1 and 2 hypertension, and it is not effective in patients with grade 3 hypertension. So the efficacy of single drug therapy is very limited in the whole hypertensive population, and again calls for a use of FDCs in a very big way. Next slide. So again, the same points here, that there is improvement in the blood pressure and better normalization, compliance is better, persistence is better, and reduction in the CV related hospitalization costs. So FDCs can reduce all of these and bring about better outcomes in our patients. Next slide. Next slide. So FDCs are combinations of either 2 or 3 drugs which can be used, and again the role of course ARBs and RAS inhibitors cannot be questioned in the management of the diabetic hypertensive patients. They bring about so many benefits in our patients: reduction in all the cardiac problems like heart failure, post-myocardial infarction problems, diabetic nephropathy, proteinuria, LV hypertrophy, atrial fibrillation, even the metabolic syndrome. So many of these ARBs have pleiotropic effects, and that helps. Of course, ACE-induced cough can be avoided with the use of ARBs. Next slide. So ARBs are, one of the preferred drugs nowadays as compared to ACE inhibitors. Of course, because of the tolerability and the safety which is there, as well as advantage of certain other things like dementia prevention. Next slide. So also, as we said, in diabetic patients, there may be other benefits apart from blood pressure reduction. That is, inappropriate gluconeogenesis may be prevented, vasodilatation, preservation of the pancreatic insulin secretory capacity, adipocyte differentiation, and also prevent hypokalemia, etc. So some of these benefits would also bring about better outcomes as far as the diabetic complications are. Next slide. So the option always there, whether to use a ACE inhibitor or a ARB. And of course, the question is there is what is the best option. I think the as far as the efficacy is concerned, ARBs are equal to ACE inhibitors, and reduction in the CV events also in high-risk patients is more or less similar. I think tolerability is one issue which is there as far as the ACE inhibitors is concerned, and also the cost factor. So I think some of the differentiating points will help us to decide which drug to be used for which patient. But efficacy of ACE inhibitors and ARBs is almost similar. Next slide. So coughing is one of the problems with ACE inhibitors. 10 to 15% angioedema. New onset diabetes will decrease, and the compliance is better. So ARBs have this advantage of no cough being there, compliance is better. New onset diabetes is also much lesser compared to the ACE inhibitors, and angioedema is also lesser compared to the ACE inhibitors. Next slide. Again, the similar advantages which have been put up here. So I think majority of us are using ARBs compared to ACE inhibitors. I'm sure many of us are still using ACE inhibitors for whatever reason, but ARBs remain the most popular antihypertensives in the management of hypertension in diabetic patients. Next slide. And of course, because the efficacy is similar and the side effect profile of ARBs is much better, it is always an advantage to use a ARB as compared to the ACE inhibitors. And of course, outcomes are better in our diabetic patients. Next slide. So although there is no RCT which has compared the major CV outcomes between the initial combination and monotherapy, the observational evidence suggests that the time taken to achieve BP control is an important determinant, and clinical outcomes in patients, especially those with high-risk patients. So, these FDCs are better to reduce all these CV risks so that, control can be achieved faster and problems can be avoided even in the short run. Next slide. So these are the various sartans which are available, and there are a lot of studies and databases there, and we can see that telmisartan has almost 51,000 patients database, various studies which are there, Transcend, Profess, On Target, and so till some time back the ACE inhibitors were one of the most studied, but now we have a lot of data with ARBs as far as the CVOTs are concerned, as well as the side effect problems which are there. Next slide. So tolerability is one of the issues, as we said, with ACE inhibitors, as well as many of the other drugs, especially CCBs and diuretics also may cause problems. But ARBs remain the drug of choice since they have minimal side effects and bring about better outcome. Next slide. So in such a situation, discontinuations are lower with the RAS inhibitors as compared to the other class of drugs. And as we can see here that the discontinuation with telmisartan and olmesartan, etc., are much lesser as compared to the ACE inhibitors and many of the other drugs. Next slide. And of course, the BP lowering efficacy which is there, or effect is there with telmisartan and olmesartan, is pretty much on lines. I mean, one of the most efficacious, of course, azilsartan is supposed to be the most efficacious drug, but here we can see that the systolic and diastolic blood pressure reduction is quite remarkable with telmisartan and olmesartan compared to the other sartans. Next slide. So the fixed drug combinations, the use of ACE and ARBs along with the CCBs provides a lot of synergy when it comes to blood pressure reduction, as well as complementary benefits as far as the outcomes are concerned. So these are some of the points which have been put forward, and I'm sure this FDC combination appeals to many of us, so that many of these problems can be balanced out. Next slide. So the combination of ACE inhibitors or ARBs and CCBs remains a very popular option for our diabetic patients. What about the comparison between CCBs and the ARBs? And here we can see the various mechanism of action of both of these. So the CCBs obviously block or diminish the calcium entry into the smooth muscle cells and causing vasodilatation and promoting vasodilatation with diminution of the peripheral resistance, as well as reducing the albuminuria, and definitely demonstrate evidence of improvements in the endothelial function. ARBs, of course, block the angiotensin 1 receptors and promote vasodilatation of the renal efferent arterioles, and similar reduction in the peripheral resistance and arterial stiffness, diminish albuminuria, and hence they bring about good blood pressure control and also demonstrate evidence of improvement in the endothelial function. Next slide. So better management, of course, leads to better outcomes as far as most of the cardiovascular events are concerned. The coronary artery disease, stroke, everything, the risk reduces. There are many studies which are there, and almost 175,000 patients have been studied, where calcium channel blockers as well as ACE inhibitors have definitely shown risk reduction as far as the outcomes of stroke and CKD are concerned. Next slide. So the choice is between using smaller doses over a period of time, or using the full dose and hitting it well. Next slide. So we have a choice of so many agents as far as antihypertensive therapy is concerned. We also know that certain drugs increase the incidence of diabetes, especially the thiazide diuretics, which may be, sometimes a problem in the diabetic patients. And in this sense, the ACE inhibitors and ARBs remain a good choice, as well as CCBs, which do not really influence the course or the outcomes as far as diabetes is concerned. Next slide. So again, CCBs are a long-standing good option in the management of hypertension. And there may be many other benefits apart from just the BP reduction for use of CCBs in our patients. Next slide. So cilnidipine is one of the CCBs which have been popular over the last few years, and there are certain advantages of cilnidipine over the regular CCBs. Next slide. So cilnidipine is a fourth generation dihydropyridine type of a CCB which was developed in Japan. I'm sure you know all of this, but the important thing to understand here is that it acts at the L-type C channels, calcium channels, as well as the N-type calcium channels, and blockade of the N-type calcium channels affects predominantly the peripheral nerve endings of the sympathetic neurons. So cilnidipine reduces the sympathetic overactivity in addition to reducing the vascular resistance, which is the property of the L-type calcium channel blockers. So there is an advantage of reducing the sympathetic overactivity with the use of cilnidipine as far as blockage of the N-type calcium channels is concerned. Next slide. Also at the kidney level, the renoprotection by cilnidipine, one of the hypotheses is that because of the blockage of both the L and the N type of calcium channels, there is a dilatation of both the afferent as well as the efferent arteriole, which gives a protection to the glomerulus. Because if it's only going to affect the efferent arteriole, intraglomerular pressure is going to increase, and that would result in more, damage to the podocytes, etc. Next slide. As compared to drug which would take care of both the afferent as well as the efferent arteriolar dilatation, and balanced vasodilatation will not increase the glomerular pressure. Next slide. So significantly reduced, glomerular pressure would, give protection to the glomerular cells and also result in significant anti-proteinuric effect. And antioxidative properties also would give a better renoprotective effect. So a CCB of choice in the hypertensive patients with diabetes, CKD, and in patients developing pedal edema with other CCBs, cilnidipine would be one of the better choices. Next slide. So cilnidipine has effect, as we said, both on the L type and the N type, and that gives it an edge over the older type of the CCBs. Next slide. Cilnidipine has similar BP lowering efficacy as compared to amlodipine, but distinct property is that it doesn't cause reflex tachycardia, lower incidence of peripheral edema. So, and also the dual mechanisms of cilnidipine explain both the low incidence of ankle edema and the excellent antihypertensive action without reflex tachycardia. Next slide. So the take-home message, as we said, is that newer CCBs, cilnidipine inhibits both the L and the N type of channels, unlike the traditional CCBs, which only inhibit the L channels. Cilnidipine is as effective as traditional CCBs for BP reduction. And cilnidipine has following advantages over the traditional CCBs beyond BP reduction, that is reduction in the proteinuria, lesser risk of peripheral edema, and possibly better improvement in the cardiac function and uric acid levels. Next slide. Next slide. So this is some of the data to support the fact that there is a better outcome with cilnidipine as far as proteinuria is concerned in the diabetic patients compared to amlodipine. So there is a reduction in the urinary albumin excretion. These were a small subset of patients who were studied, and the concentration of urine albumin was measured. Next slide. And patients were randomized to receive cilnidipine and the other CCBs. So cilnidipine group had a lower proteinuria than the amlodipine group. That is what this study is telling us. Next slide. So reversal of LVH is also better with cilnidipine than the other CCBs, including amlodipine in the hypertensives with CKD patients. Again, this is some more data. Next slide. So cilnidipine and ARB combinations also offer better cardiorenal protection in patients with hypertension. A combination therapy of both of these would give us better outcomes. Next slide. And this is again one more study with 45 patients who were randomly assigned to a RAS inhibitor, but with cilnidipine 10 to 20 mg, and RAS inhibitor with amlodipine. Next slide. And the LV mass was significantly reduced in the cilnidipine group compared to the control group. And these results indicate that cilnidipine is beneficial for the suppression of the pathological cardiac remodeling, as well as improving the LV function in hypertensive CKD patients. Next slide. So also the antioxidant effect and the other benefits of cilnidipine helps to improve the outcomes in these hypertensive patients. So this combination of cilnidipine and telmisartan with all the data which is there should give us confidence to be used in the diabetic hypertensive patients to bring about better clinical outcomes. Thank you. Thank you very much.
Thank you, Dr. Kulkarni. I think excellent talk. You had covered all the color. So I think, Kapil, we are going to have a question at the end.
Yeah, we will have a question at the end. So I request, so I request Kulkarni sir to stay back for for the panel discussion and question answer. Thank you so much, sir, for covering that fixed dose combination and little doubt about diabetic and hypertension. There are a lot of questions we'll try to answer at the end of the talk. So I thank you once again, you and Dr. Dargat, for this session. So last in this evening there is a so the concluding talk will be by Dr. Arun Shah. And for that, I'll invite the chairperson, Dr. Sharad Seth, sir. Sharad sir, are you there?
Yes, Dr. Raki, can you hear?
Okay. Yes, sir. Okay. So, let me introduce Dr. Sharad Seth, sir. I think sir doesn't know need any introduction, but as a formality, sir has been head of department at Kokiraben Ambani Hospital, and sir has been always there for us for any kind of talk, any kind of help, and he's always a man to go for any kind of whenever we are in some problem, we always call him, and he's always ready to help us out. So I leave it to Sharad Seth, sir, to introduce our next speaker. Over to you, sir. Sharad sir,
please unmute yourself, sir.
Am I audible now?
Yeah.
Yeah. Dr. Arun Shah is a senior nephrologist attached to Lilavati by multiple publications. He was awarded IMA 2013 Best Clinician and Academician in Nephrology. Vice President, Mumbai Kidney Foundation, and Treasurer in Corrupt Trust. Amar Gandhi Foundation. Yeah, please take over the mic. And
thank you, Dr. Sharad, for the kind introduction. I also thank my previous speakers, Dr. Pandey and Dr. Kulkarni, who has made my talk simplified so that I can straight go on to a clinical case. At the outset only, I would like to thank moderator Dr. Kapil Rathi and Dr. Ashish Bidla, and thanks to JB Chemicals for arranging this webinar in association with Andheri and Parla Physicians Association. Now, I will start straight with a case which you see in your day-to-day practice, what happens in a patient with diabetes, hypertension, and chronic kidney disease. We have various drugs, we have various combinations for diabetes, for blood pressure, but actually when we are treating a patient, what actually we are supposed to do, and what all things we have to look into. Next slide. Now, this is a classical case which we see in our practice. A 63-year-old male with poorly controlled blood pressure, diabetes, is dyslipidemic, obese, is gout, sleep apnea, is a smoker. His current medicines include amlodipine, hydrochlorothiazide, clonidine, atorvastatin, metoprolol, insulin, glargine, metformin, allopurinol, 300 milligram, omeprazole, and CPAP at night. Next slide. Now, continuing the case, his BP is 150 by 86. So it's not well controlled. Sugars are 10.4, HbA1c poorly controlled. He's anemic. Hemoglobin 9.5, LDL is 35, LDL 240. His triglycerides are 295, calcium is 9.8. Urine protein creatinine ratio is 1.2, creatinine is 1.7, and GFR is 39. So what should we do for this patient? Is he on the right treatment or something wrong is going on? Next slide. So if you shortlist a diagnosis in this patient, he has a urine protein creatinine ratio of more than 30, GFR is less than 60. So he has a stage 3B albuminuria 2 CKD, and this puts him at moderately high risk of developing end-stage renal disease. Next slide. So now going back, some theory and some practical points. What is the definition of CKD? All of us know that criteria for CKD is when either of the following is present for more than 3 months. Markers of kidney damage are albuminuria, any urine sediments for like RBCs or CAS for more than 3 months, electrolyte abnormalities due to tubular disorders, any abnormality detected on biopsy or structural abnormality seen on sonography, CT or MRI, or any history of kidney transplantation, even if creatinine is 0.9, we call it CKD. CKD. Any patient who has a decreased GFR of less than 60 ml for consistently more than 3 months, then he's got chronic kidney disease. Next slide. So now in diabetic kidney diseases, the classification does not stop at only GFR. It also includes albuminuria. GFR staging remains same. Stage 1, 2, 3A, 3B, stage 4, and stage 5. That is GFR staging. And a patient has albumin creatinine ratio of less than 30, it is A1. If it is between 30 to 300, it is A2, and more than 300, then it is called as A3, and it suggests very poor prognosis. Next slide. Now this particular slide is a very favorite of all nephrology residents and consultants. This in one shot gives you idea which are the patients at a very high risk of developing end-stage renal disease. So even if somebody has a GFR of more than 90, but if he has grade 2 or grade 3 albuminuria, which is more than 30 to 300 milligram or more than 300 milligram, then is quite a crippled patient. This diabetic patient is unlikely to respond well on a long-term basis, and it will definitely develop end-stage renal disease in next 3 to 10 years if his blood pressure is not controlled. So all the bars in dark red, and orange color, they suggest poor prognosis of the patient. And this is correlated not only with GFR, but also with the proteinuria of the patient. Next slide. So what are the stages in progression of CKD and therapeutic strategies? So any patient with diabetes or hypertension or stroke is potential patient for CKD. So you start screening this patient for CKD right at the beginning of the diagnosis of their hypertension or diabetes or obesity. When there is an increased risk, you have to further intensify the screening and you have to try to reduce the risk of CKD. When there is a damage to the kidney, you start very effective treatment, treat the comorbid condition and try to slow down the progress. When the GFR comes down, you try to treat the complication and prepare the patient for renal replacement. When there is a kidney failure, you talked about replacement by dialysis or transplant. And our aim of the treatment of diabetes and hypertension is to prevent CKD death. Next slide. So once you have identified CKD, what are the risk factors? Any hypertension, diabetes, age more than 60 years, family history, patients who are taking a lot of NSAIDs, those who have cardiovascular disease, those who had acute kidney failure due to any cause, autoimmune diseases, urological disorders like stone or obstruction, systemic infections, cancer, and certain ethnic minorities like African Asians and other population. They always said CKD risk. And in these patients, what are the indicators of kidney damage? Proteinuria, hematuria, any persistent urinary sediment abnormalities, structural abnormalities of the kidney on imaging studies, persistently low GFR and other abnormal blood tests. Next slide. So what does the KDOQI say? The Kidney Disease Outcome Quality Initiative says that evaluation of patients who are at risk for CKD. So all the patients who have blood pressure, you should do creatinine to estimate GFR, you should do protein to creatinine or albumin to creatinine ratio in a first morning sample or a spot urine sample. You should do examination of urine sediments with dipstick for red blood cells and white blood cells. And selected patients, you have to do electrolytes, you have to do specific gravity, sonography, CT scans, MRI, and urine acidification studies. So any patient with diabetes, hypertension, stroke, obesity, family history of CKD, and cardiovascular disease, you should be screening them with the measures given in the table. Next slide. Now, going back to our patient, he has got hypertension, he has got anemia, he has got a kidney disease, he's got bone loss, he has got diabetes, proteinuria, and hyperlipidemia. So this is, we are just kept putting it at the back of the mind, what all complications and comorbidities our patient is having. Next slide, Millard. So when you review the medications, what we have to first do is we have to see that we stop the drugs which are dangerous in him and we have to modify the dose. If he's taking any NSAIDs or Ayurvedic drugs, we should stop that. His metformin can cause lactic acidosis when GFR is less than 30. So we have to reduce metformin dose at that time. He's got gout and he's on allopurinol 300 milligram, but since creatinine is high, we should reduce allopurinol to 100 or 200 milligram as required and try to avoid biphosphonates in this patient because that can produce acute kidney failure, allopathy. There are certain drugs you will have to modify in this patient and think quickly and change the drugs quickly. Next slide. Next slide, yeah. So in this particular patient, he is on amlodipine and hydrochlorothiazide, but BP is still not controlled. So what should we do for that patient? should either the ACE inhibitors or ARBs to reduce proteinuria, which is 1.2 grams, and delay the CKD progression. Now, it is known that when you start ACE or ARB, the GFR initially decreases. And up to 25% decrease of GFR, you can wait. Now, here the creatinine went up to 2.1. So, it still the ACE or ARB was continued. His potassium was good at 4. So, ACE was continued. Only in patients where potassium is more than 6, at that time, you stop ACE or ARB immediately, and after, once the potassium is corrected, you can reintroduce ACE or ARB with half the dose. You may add hydrochlorothiazide or chlorthalidone to keep that potassium under check. And you put this patient on a very strict low potassium diet, because ACE and ARBs are more important drugs in diabetic kidney disease and proteinuric kidney disease than any drug in our armamentarium, except the new SGLT2 inhibitors, which have been shown to reduce proteinuria. ACE and ARB are the drug of choice. Now, recently, there are a lot of studies in European and American trials that patients who require ACE and ARBs, and in spite of their diet control, even if potassium stays up, you put the patient on petitomar, that is oral hypokalemic agents, and continue ACE or ARB. So the main thrust of this talk is that ACE and ARB should not be abruptly changed stopped in these patients unless the potassium is more than 6 or he has got severe allergic reaction to ACE or ARB. Now, once you start it, ACE, the BP goes down to 130/70. Now, the target blood pressure is achieved with starting ACE. So, if we can stop the drugs which are not going to benefit his kidney, like clonidine or alpha blockers, which are in, if their patient is going on, then you can stop that. But ACE/ARB or dihydropyridine and diuretics, they remain the cornerstone of treatment of hypertension in patients with diabetes, hypertension, and CKD. Next slide. Now, hypertension is a major factor responsible for decline in kidney function in patients with diabetes and non-diabetic kidney disease. Hypertension may develop early during the course of CKD. It can be cause and consequence of CKD. And CKD patients more likely to develop masked hypertension. And the first sign of patient developing hypertension in CKD is loss of nocturnal hypertension. The patient develops nocturnal hypertension and there's non-dipping of blood pressure. And that is the first manifestation of diabetic kidney disease. And then they develop hypertension, then they develop proteinuria. So non-dipping of blood pressure occurs almost at the time of hyperfiltration of the kidney, when glomeruli enlarge, when the creatinine comes down in the beginning of diabetic kidney disease. Next slide. So prevalence, if you look at this slide, it's a very interesting that patients without CKD, they could be in normal population, in urban population, 11 to 25% of individuals have hypertension. When there is stage 1, there is 35%, stage 2 CKD 48%, by stage 3, 60% of patients, and by stage 4 and 5, 85% of patients have hypertension. Next slide. So how do you manage hypertension in patients with CKD not on dialysis? So non-diabetic, not on dialysis CKD patient, target goal is when patient does not have albuminuria, means albumin in 24 hours is less than 30 milligrams and office BP is more than 140/90, then you use antihypertensive drugs to maintain BP below 140/90. Now these guidelines are by KDIGO in 2012. Recent guidelines, they say that you come down up to 130/80 And if the blood pressure, low blood pressure is well tolerated by the patient, you can go up to 130/75. When albumin excretion is more than 330 to 300 milligram per day, and BP is more than 130/80, your target is blood pressure control of less than 130/80. And when proteinuria is more than 300 milligram per day, then any office BP of more than 130/80 should be treated to a target blood pressure of less than 130/80. In diabetic hypertensive patient, the important thing is how well patients are tolerating decrease in blood pressure. Normally, when we check the blood pressure, it is either in supine position or sitting position. Now, the same patient, when he gets up, his BP suddenly drops and there is a postural hypotension and he can fall. So we have to be slightly very careful about the symptoms of giddiness while walking, while controlling the blood pressure. Patient should not fall if you control the BP at a lower level. But otherwise, it is said that lower the blood pressure in diabetic disease, better it is for the patient. But in clinical practice, anything about around 130/80 supine or sitting blood pressure is tolerated well by the patient. If you bring it down further, they have hypertension on standing. Next slide. So this was non-diabetic patient. In diabetic non-dialysis patient, again, the target is to bring down BP to less than 130/80. But moment they have proteinuria, then you can become more intensive in treating this patient to 130/80, 130/75 range. Next. So recently we had a sprint trial about 5 years back, and it showed a lot of benefit with further control of blood pressure to less than 120, 115, 110. But they also showed that there was a hemodynamic changes in the kidney because of the low blood pressure and GFR fell. So they, with different studies, they have shown that it is more of hemodynamic change rather than pathological change in the kidney. But our observation in our patients, Indian patients, is that moment you still further bring down the blood pressure to 120, 110, they develop a lot of postural hypertension, they develop fall and fractures. Next slide. So management of hypertension in patients with CKD pre-dialysis target goals. In addition to blood pressure control, specific goals related to reduction in urinary protein excretion have been formulated to slow the rate of progression of proteinuric CKD. Proteinuria goal of less than 1000 milligram, still better is less than 500 milligram, or proteinuria of at least 50-60% reduction from baseline should be the target when you treat the patient for hypertension in a diabetic patient. Next slide. Next slide. A management of hypertension in patients with CKD. What are the lifestyle recommendations? So whether you're talking about diabetic patient, non-diabetic patient, proteinuric patient, non-proteinuric patient, the first treatment is lifestyle recommendation. So this comes on the top of every treatment of hypertension. DASH diet, that is dietary advice to stop hypertension. Patient should have a diet rich in fruits, vegetable, and low in fat and non-fat dairy. Here it is a problem in kidney patients. This diet rich in fruits can cause hyperkalemia. So you have to be very careful about potassium in CKD patients. And the more important in proteinuric patient is ACE and ARB. So if you have to give ACE or ARB, the potassium is somewhere above 5, then hold back fruits. If required, give small diuretic or you give petit tumor, but give ACE and ARB to control that proteinuria and blood pressure. You must keep healthy weight, BMI between 20 to 25, lower salt intake of 2 grams of sodium or 5 grams of salt, that is flat teaspoonful of salt is about 4 to 5 grams. Patient should walk at least 30 minutes 5 times a week. He should limit his alcohol intake. And the most important is to stop smoking, tobacco, and Ayurvedic and painkiller medications. Next. Now, what are the choice of antihypertensive therapy in proteinuric CKD? First line is ACE and ARB. This is to lower BP and slow the rate of progression of CKD. And it has been shown in n number of studies in both ACE and ARBs. And it is a great drug for diabetic CKD patients to control proteinuria and hypertension. And repeatedly, I'm emphasizing that everybody tends to stop moment potassium becomes 5, 5.5. But tell your patient to become very strict on low potassium diet, add small thiazide diuretic if GFR is more than 25, 30. And in selected cases, you can also give petitumor. The second and third line drugs, if patient is edematous, then I give cilnidipine. If it's not edematous, then I may give amlodipine. Then if there is a lot of edema, then I'll give loop diuretics with it to reduce the volume status. If there is no edema, I may give hydrochlorothiazide or chlorthalidone. Now about diuretics in diabetes and hypertension, there are two important things. The thiazide diuretics, both chlorthalidone and chlorthalidone, they are excellent antihypertensive drugs, but they are poor diuretics. While loop diuretics, which you have to use once GFR falls below 25, are excellent diuretics, but they are poor antihypertensive drugs. So sometimes in a patient where GFR has fallen below 25 and patient is edematous and BP is not controlled, you may give loop diuretics to remove that water, but you may have to give chlorothiazide after your ACE/ARB or calcium channel blockers. With that, you add some chlorothiazide or chlorthalidone to control the blood pressure in a better way. Next slide. So what are the choice of antihypertensive therapy in non-proteinuric CKD? So it depends upon the volume status. If edematous, give loop diuretics, ACE and dihydropyridines, CCBs. If no edema, then you can start with ACE and ARB, dihydropyridine and diuretic as a third line. So in a diabetic patient, if he has proteinuria, ACE/ARB remains first, cilnidipine, that is dihydropyridine becomes second line, and diuretics becomes third line. Next slide. Now, the general considerations when you use antihypertensive therapy is sodium restriction. It will improve the efficacy of many drugs. Diuretics, higher doses are required, and thiazides are less effective or rather not advocated once GFR falls below 30. And fourth line drug, mineralocorticoid receptor antagonists like aldosterone antagonists, aldactone and eplerenone. In the newer drug, the recent Bayer's trial came out last week. The results, official result will be out on 21st of July about finerenone, which is a non-steroidal mineralocorticoid receptor antagonist. And they have shown that it causes lesser steroid side effects, lesser hyperkalemia. And it has been suggested in a lot of resistant hypertension studies to use these drugs to control the blood pressure to the required level. In CKD patient, the worry is potassium. So if your potassium is not very high, it's still below 4.5, you can use mineralocorticoid receptors as a fourth line of drugs. And if BP is not controlled with the one dosing, then you can split the dosing. To morning, you can give ACE/ARBs with diuretics. Night, you can give dihydropyridine like cilnidipine or amlodipine or azilipin, whichever patient is on. So if you split morning and evening and give a nocturnal therapy, then patient's BP control may be better. Next slide. Now, physiology-based, this is again an algorithm for initiation and management of resistant hypertension in CKD. So they say that the patient has a low PRA, plasma renin activity, and if urinary sodium is more than 150 micromole per day, if he is edematous and if he has a reduced GFR, then you optimize the diuretics, then you can give diuretics for a longer period of time. You may have to give loop diuretic if GFR is low, and you can give it with ASARB and dihydropyridine. If patient is high plasma renin activity, where your RAS activity you have to block, then your ASARB, aldosterone inhibitors, and sometimes the beta blockers, which also reduces the RAS activity, can be given to reduce the blood pressure. And choice of hypertension mediated by sympathetic nervous system, when there is tachycardia and congestive heart failure, you have to use beta blockers, newer beta blockers like carvedilol or Concor and other things to control the blood pressure better. And if patient is going in repeated cardiac failure, then you can use sacubitril. Next slide, please. Now our own patient, for his diabetes, his HbA1c was about 10. He has to start on diet and exercise program. We have to set a goal for him. We have to intensify his insulin regimen. We have to eat DPP-4 inhibitors. We can use liraglutide, glipizide, and SGLT2 inhibitors, because still this thing is more than 30, your GFR, and you control his HbA1c. Now, HbA1c is a very peculiar thing. When patient is still not into CKD, GFR is more than 60, your target is HbA1c of 6.5. But moment he starts developing race creatinine and GFR falls, the HbA1c, you should keep it at 7 or somewhere around that, so that they don't go in hypoglycemia. Here, my another advice to the practitioners is that all diabetic drugs are metabolized less in CKD, and they maintain their higher levels in the blood. So when they start developing hypoglycemia, rather than reducing the drugs drastically, what I would advise you, improve the calorie intake of the patient. All CKD patients, you are going to reduce the protein intake to prevent progression of disease. Now, when you reduce the proteins, there's an adaptive mechanism in the body. The less proteins are broken down, more proteins are recycled back into the body, and less waste products of proteins are produced by the kidney. But this can happen only if caloric intake is very good. So rather than drastically reduce the antidiabetics, improve the caloric intake of the patient and try to maintain the sugar. Next slide. So in diabetic kidney disease, about 30% of diabetic patients develop some form of kidney disease. Terminology changed from diabetic nephropathy to diabetic kidney disease to encompass whole range of glomerular, tubular, vascular, and urological problems in diabetic patients. It accounts for most common cause of end-stage renal disease. Almost 40% of our dialysis patients are diabetics, and major cause of morbidity and mortality in diabetic patients. Next slide. So stages of diabetic nephropathy, there is hyperfiltration, then there's a silent stage. In hyperfiltration stage, patient will come to you, oh, my creatinine has come down to 0.6, 0.65, but that is the hyperfiltration stage. Silent stage is where there's some mesangial thickening occurring, but some glomerular basement membrane is thickening, but GFR is normal. incipient is one where proteinuria starts coming up between 30 to 300 milligram. Then there's overt diabetic nephropathy with decreased GFR, hypertension, raised creatinine, and then you develop end-stage renal disease. So this is how the diabetic kidney behaves. Next slide. So this is a list of anti-diabetic drugs which we advise in CKD. So the green bars which go right up to the end, and the yellow bars which the green bars which go right up to the end, you don't change the dose of the drug, while the yellow bars which goes right up to the end, you can continue to use them during all the stages of CKD, but you have to reduce the drugs. So which are the main drugs to enumerate for you? It is glimepiride, glyphosate, glyclazide, the linagliptin, DPP-4 inhibitors, and insulin, and pioglitazone. But as Dr. Ponde very elegantly showed, that this causes the increase in weight, and before you give any pioglitazone, you have to do the EF of the patient. If ejection fraction is less than 45%, you can't give pioglitazone, but otherwise it's a great drug to continue during all stages of kidney disease. Next slide. Insulin-based regimens are commonly used in CKD patients because they are safe. You use short-acting insulin so that there is no long-term hypoglycemias. Insulin requirement further decreases when urine output drops, and in peritoneal dialysis, you can add insulin to peritoneal fluid. Next slide. So these are some new pharmacological agents for protecting kidney function in type 2 diabetes. And the most important what Dr. Ponde told us is about SGLT2 inhibitors. Now the talk has come from use of SGLT2 inhibitors in heart failure and prevention of proteinuria in diabetic kidney disease. Its action as hypoglycemic agent is now being marginalized. Everybody has realized it doesn't do much reduction in sugars, but it's a great value in heart failure and reduction in proteinuria. There are newer drugs which are being worked out like atrasentan, VEGF antibodies, pirfenidone to reduce interstitial fibrosis. Then the other drugs are in trial, but nothing has shown still great advantage. So maybe in next 3 to 5 years, we'll have some more treatment coming up in diabetic kidney disease. Next slide. So this outpatient, it is not only aim is to take a look at blood pressure, diabetes, cholesterol. We have to protect his heart also. So you have to start on atorvastatin. It is advised that all the patients with CKD, you give atorvastatin other than rosuvastatin. Start with small dose of aspirin, stop smoking. People add fibrate, but my observation is that when you give fibrates for triglycerides, the creatinine tends to go up. So be a little careful with that. You have to reduce the food causing high triglycerides, and you have to rule out subclinical hypothyroid in this patient to control the triglycerides. Next slide. So the principles of management: control BP below 140/90, 130/80, 130/75, HB1AC7, and proteinuria as much, whatever you can do to control protein. AS, ARB, cilnidipine, aldactone, mineralocorticoid receptor blockers, smoking, everything you do, but reduce proteinuria. That is going to protect your kidney. Next slide. So again, coming back to protein restriction, statin therapy, smoking cessation, avoid NSAIDs, ayurvedic drugs. I have put up these principles in the chart which I give to the patient. This is what you are supposed to do, so that they don't keep on asking what next, what next. The treatment of kidney disease, there is no great drug. The drugs are control of blood pressure and diabetes. Next slide. So I will just conclude my talk here. There is early detection of CKD is done by family physician, and every patient with hypertension, stroke, obesity, and diabetes is a potential CKD patient. Aim is to prevent progression of disease. Early referral to nephrologist for guidance helps prevent many complications. CKD is preventable if etiological factors are treated early. Encourage your patients to take proper treatment. It's not the end of the road. Thank you.
Yeah, thank you, Arun Shah sir, for that comprehensive and exhaustive coverage of CKD in a triad of diabetes as well as hypertension. Thank you very much. So we are just done through all the lectures. I request Milan to make all the panelists and chairperson on the main screen, please, so we can have a little panel discussion, quick questions, and
done, sir.
then we'll call.
They're on main screen.
Yeah. So everyone is there.
Except Dr. Birla is not there, but Dr. Ponde is not there. Yeah.
Dr. Ponde sir has left actually. He has got some prior commitment. So I think he has to leave for them.
Okay.
But we have got other panelists to start with. So can I? Okay. So let me ask one question because Ponde sir is not there, so probably Dr. Ratnaparki sir will answer this question. So sir, as sir has shown exactly that in one of his slide he has shown that there was a relative risk reduction to the tune of 42% with the drug called hydralazine and isosorbate dinitrate. So that was, I think. Yeah, so there was 42% reduction in relative risk reduction in the patient with that. So how do you feel this combination in a typical in a typical heart failure patient, Dr. Ratnapargi sir?
Yeah, this was a trial before ACE inhibitor ARB and ARNI era.
Yeah.
So after coming of ACE inhibitor ARBs and ARNI, this combination has shifted to a third position. If patient is unable to take ACE inhibitor ARBs, then that is the only indication where combination of isosorbate nitrite and hydrazine should be given. Otherwise, it is not useful.
It's an old study, so probably at that time it showed more result, because dihydroxyzine and isosorbate came much earlier than ACE, ARB, ART, and your SGLT2 inhibitors.
Safety-wise also, hypertension are very hypertension episodes are very frequent there because we have to this drug 2 times or 3 times a day. Okay, so significant side effects. So this has shifted on 3rd or 4th place in the management.
But Arun, I think nephrologists do use many times where your potassium is high. I think you have to take rescue of this drug many times. Especially in hyperkalemia situation, we still want the blood.
They use in combination or only hydrazine?
No, in combination. Isolazine is available, so we use.
We have a hydrazine plain available. We have a hydrazine now pill.
Hydrazine now available, yeah.
Okay.
US they use a lot of hydrazine for resistant hypertension in US.
Okay,
correct.
Lots of hydrazine they use, yeah.
Okay, sir. Another question. Dr. Kulkarni will be here, so I'll ask this question to 2 people, a cardiologist as well as a diabetologist. Now, we all know for all the heart failure patients who have got HEPREF ejection less than 40%, there is a clear-cut guideline. You have to use ARNI first and later on second. But people who have got medium range between 40 to 50, and people who have got more than 50, which more of our diabetic people will be heart failure will be with preserved ejection fraction. So in such patients or these patients, so all these patients should be started on SGLT2 inhibitor, or we should actually wait for for some data, because ARNI is very clear cut in less than 40%. But from 40 to 50 and 50 above, I think there are not many drugs which are available. So SGLT2 is the right choice. Do you agree, sir, with this? Ratnaparki sir, And Kulkarni sir?
See, as you correctly said that we have the data, enough data of RNA with a LV function less than 40 or 35. There is no data which can dogmatically say that you can use in the preserved LV function also. Regarding SGLT, I mean, let Dr. Sudhan Kulkarni answer that question. But the data of DAPA-HF trial, only 1,000 patients were there. Okay, so mind well that we also require a huge trial in all the steps of diabetic and non-diabetic to really, whether it is really useful or not in non-diabetic status or not. It require a huge data use study also. Sudhanshu?
Yeah. I think I agree with Dr. Ratnaparki that I think we are waiting for more data. I think related to all this heart failure, these studies which are going to be there. So one point which I wanted to make, is that with the SGLTs, I think with the various, SGLTs which are available, EMPA, DAPA, CANA, and of course ones which are not available also in India. I think there are a lot of these CVOTs which are there, and I think EMPA has, most shown the most promising data as far as CV outcomes is concerned, the 3-point MACE as well as the hospitalization for heart failure. Unlike the other ones, which have not shown, that much of a benefit. But as far as, of course, your question is concerned, I think SGLTs are a choice as far as, reduction of for hospitalization for heart failure is concerned in the patients with FREF, no doubt about that. And also in the non-diabetic, I think we have some data already available as far as DAPA is concerned, of reducing the HHF in patients with without diabetes also.
This DAPA-HF trial, the LVF is either 40 or below 40. Okay. But
I think if you have to add one point, I think SGLT is all the trial on preserved ejection fraction is on. By the end of 2020 or 21, we will get all the data. Today we have a reduced ejection fraction. There's a clear DAPA-HF trial, but both EMPA, CANA, and DAPA, all three have a trials on preserved ejection fraction. Some will come by December this, and some in the 2021. Once those data come,
theoretical the pleomorphic effect, reduce the fibrosis, interstitial edema, all these things
should be help it.
Whether favors in all the heart failure, whether it preserved or reduced. So theoretically, yes, it can be used in all the spectrums of heart failure.
But I think till the outcomes of all the trials come of preserved ejection fraction, then only we'll get an official approval. But I think today reserved ejection fraction, definitely we have that data.
Definitely.
Okay. So on the same
Can
line.
I make one point? Sorry.
Oh, yes, please.
Yeah, I think earlier on there was a discussion about the GLP-1 RAs, So, and used in, so I think the guidelines, clearly mention that if you have ASCVD, GLP-1 RA remains a treatment of choice. And of course, the latest, data related to GLP-1 RAs is on the dulaglutide, the Rewind, study, which was there, and the CVOT. I think they have just released it in India, which has, actually surprised, in the sense that, in leader, we had some kind of a good or actually non-inferiority which was there. Even in Rewind, I think that trend has remained, that there is non-inferiority as far as 3-point MACE is concerned. So I think what I'm trying to say is that SGLTs, still remain or they have shown, an edge over the GLP-1 RAs also, which was surprising to me, And as I said, EMPA has one of the most compelling evidence as far as, CV outcomes is concerned.
Even this recent European guidelines has question marked the utility of this GLP agonist in the management of heart failure also. So probably future, whenever insulins are required or when, then GLP agonist may be taking place there.
Okay. Now, staying with the same SGLT2 inhibitor, let me bring both nephrologists into the picture. Now, all our diabetic patients, sir, we are more or less nowadays it's people will have an SGLT2 inhibitor, and there is a lot of 45 is the cutoff for practically all of the SGLT2. But looking at the data in the renal protection and everything, so are you guys nephrologists are brave enough to continue SGLT2 till your eGFR is 30, or you stop at 45?
In fact, trials which are some places, those they have shown a lot of improvement in proteinuria. Those trials were up to GFR of 45, but some centers are doing trials on GFR up to 30. So maybe in next 2-3 years, you will get data on GFR of let's say up to 30 also. And that is where you will be able to see a lot of reduction of proteinuria.
What about transplant dialysis patient? Are you going to use them SGLT?
No, SGLT, you have to have urine output. Dialysis patients are anuric, almost all of them.
Okay.
It is not useful.
Okay. Sharad sir, are you there?
Kidney.
Yeah, go ahead, sir. Okay. I think okay, sir, one more question to
Renal cortex.
Okay, I think we have got some connection problem with Sharad sir. Okay, moving on to the next question to again nephrologist. Sir, you guys, nephrologists are more fond of calcium channel blocker like fourth generation, like either any either cilnidipine or for that matter azanidipine or ifenadipine and everything. So what we are also seeing is that there are a lot of pleiotropic effect, but they are not very good antihypertensive. So still amlodipine has got edge over that cilnidipine. So whether you are fond of cilnidipine just because of the pleiotropic effect, or really it does decrease BP to that extent? And in other way, what I'm trying to ask is if someone is on amlodipine, whether we change to cilnidipine or any other newer calcium channel blocker. That is the
so I will give my practical answer. Now, cilnidipine came around 2011. It was introduced by JB Chemicals. And when we started talking about cilnidipine, there was a lot of resistance by everybody. Why give a costlier drug and other things? But if you see data from Japan and Korea, they have used this in the last 20 years. And they have shown good effect on blood pressure over a period of time. It is not rapidly acting like amlodipine. So how do I use in my practice? The patient is edematous. If he has recently gained weight, I do not give amlodipine. If I need CHB, then I put on cilnidipine with a diuretic. But with the readiness in the mind, it is going to act slowly and control the blood pressure slowly. But if you need, suppose somebody comes with a 200 blood pressure and you need to bring down blood pressure to 130, 140, then start with amlodipine. Look at the edema, what happens in next 10 days. If edema goes up, the weight goes up, withdraw amlodipine in 10 days. Meanwhile, you start introducing cilnidipine. So that is how I practice, clinical practice. There is no great advantage on proteinuria because the studies are 200 patients, 300 patients. They are not large studies. So it is mainly the venodilatation which prevents edema, and that gives a lot of psychological effect to the patient. Oh, my swelling has gone. And that happens in almost 80% of patients where edema is an issue with amlodipine. And over a period of time, 15, 20 days, 1 month, the BP comes under good control. Like amlodipine, only thing you have to understand is you have to double the dose. If you are giving 5 milligram amlodipine, you have to give 10 milligram of cilnidipine. So that is how we have to work on it,
Okay, a quick comment on cilnidipine by diabetologist as well as cardiologist, because kidney, a lot of people feel that this newer calcium channel blocker, they are more with nephrologist and less with diabeto and cardiologist. So your take, Kulkarni sir first and then Ratna Parke sir. Kulkarni sir?
You have to unmute yourself, Kulkarni sir.
Sorry. Yeah, I think the use of cilnidipine has been increasing in our clinical practice, I would say. I mean, as far as efficacy is concerned, I think the efficacy is very much there. But as we saw in the presentation, that there are some advantages of cilnidipine as far as the mechanism of action is concerned, etc. And I think that gives an edge. So I think cilnidipine is becoming more and more common as far as the combination, is concerned with the ARBs in our practice.
So, Ratnabhargi sir, do you also feel the same in cardiology practice?
I think as an antihypertensive agent, amlodipine outscores because of legacy of more than 20-25 years and outcome trials, mortality benefits. Nephro point of view, because of the efferent dilation effect and reduction in the proteinuria, these are the most important, if a very subtle effect of. So more used by nephrologists.
I
Okay.
think another important.
Once the dose you increase, go on, it increase to TDS, BD, 10 mg TDS or BD, because I've seen so many nephrologists writing BD or TDS. Then the edema will be almost same what you get in the amlodipine patient. So in some of the population you may use cilnidipine, but as a pure antihypertensive agent, amlodipine always outscores.
Yeah, Arun Shah, sir, you are making some comment.
The only point about cardiology effect is the pulse rate, with cilnidipine. Amlodipine causes some reflex tachycardia, while cilnidipine, by its effect on the CVS system and the heart, it either maintains the pulse rate or slightly reduces. And it has been shown in various trials in Korea and Japan. So that's the only benefit that has been shown. And in kidney, it also has a lot of effect on the interstitium, and it prevents interstitial fibrosis and tubular atrophy. It is not only about glomerulus, it is about the interstitium. If interstitial fibrosis and inflammation, if you can bring down, then you can prolong the life of the kidney. So there was a lot of resistance 7, 8, 10 years back on using cilnidipine, but now people have started accepting it. The cost has come down. People know how much dose to use. See, amlodipine, if you see, nobody gives 20 milligram BD or 10 milligram BD. We give at the most 5 milligram BD. So cilnidipine, if you give 10 milligram BD or TDS, nothing will happen. But the moment you go to 20 TDS, the swelling will come up. Because then it becomes like giving amlodipine 10 milligram 3 times,
Okay. So couple of last questions and then we'll call it a day. So one question, one very important question to Dr. Ramesh Dargad sir as well as Kulkarni sir. So as Dr. Ponde has given in his talk that almost 1/3, 30% of your diabetic will be heart failure patient. So considering there are 10 crore diabetics, 10 crore diabetics in India, so almost we are targeting about 3 to 3.5 crore heart failure patient in making. So how early we should evaluate this patient of a diabetes for heart failure? So what I'm trying to ask is clinically and also how early we should screen this patient for heart failure, and what are the early pointers where patients are getting in a heart failure? How can we do it clinically? So both of them you can answer, sir. Dargad sir as well as Kulkarni sir.
I think the first thing, everybody who is diagnosed diabetic, they have some already complication like proteinuria and all that we see that, and sometimes seen quite early in a pre-diabetic diabetes. So I think whenever the diabetes first time diagnosed should have a baseline 2D echo at least for him. So maybe it's possession. And I think the patient does have a symptoms. I think then even the biomarkers will be helpful to know some of the patients have a failure symptom. But at least a baseline echo along with ECG should be done to screen at and then at regular intervals of every year when you do like a retinopathy and all that, there should be cardiac markers or the echo should be done because we have large population. Is 1/3 is quite a big number. The 33 crores of population will be required and they're being not completely treated. And if we start early, whether ACE, ARB, ERNI or SGLT, we can large extent prevent that further complication. Though they may not have ischemic RTC, they may not have blockage. The non-block 1/3 population has normal angios and still they have a diabetic cardiomyopathy. And if they are going to progress, they're going to be a big burden, repeated hospitalization, everything. So you start early with the proper drug, but there the role of SGLT will come a big way, which can prevent, apart from ACE, ARB, to start early. So we can prevent this hospitalization to these patients actually. That's, I think, Kulkarni sir comment.
Kulkarni sir, anything to add, or we should do anti-BroPNP at the moment we diagnose diabetes or a patient so it should be one of the tests in your checklist whenever you evaluate the
only patient is symptomatic. I don't think every patient, but I think 2D echo and ECG should be done for every patient. Probably will be quite expensive thing for a routine everybody to screen. But if somebody has written slight dyspnea on voice exertion, something symptomatic, I think then we should do. Maybe echo may look sometimes normal in that situation. Because
So Kulkarni sir, you follow the same pattern?
Yeah, Kapil, I think I'll agree with Dr. Dargad's most of the points which he has put forward. The interesting thing is that, subclinical cardiovascular disease in diabetic patients, has been studied, and the, incidence has been anywhere from 15 to 50%, in various studies, even in the Indian studies. So I think it's not surprising actually that, cardiovascular disease is a very common problem in our diabetic population. I mean, as far as this specific question which you have asked, I don't know whether the guidelines actually, have recommended anything like this. So I think this whole thing about, the CV aspect of diabetes actually is coming into focus with the SGLTs coming, So I think guidelines are evolving, and I'm sure in the near future, maybe these tests will be recommended, maybe not routinely, because maybe they are a little expensive to be done in all patients, but at least a few of the basic tests which Dr. Dargad has mentioned, I'm sure is what at least we can do, in our patients.
So Ratnaparki sir, one question to you.
Kapil, to add this, there was a study that pre-diabetes, HbA1c 5.5 to between 5.5 and 6.5, they found that significant number of patients will have higher troponin T, so-called subclinical evidence of diastolic dysfunction. Something. Those are diabetic, yes, they have significant troponin T in most of the patients, and HbA1c less than 5.5, they have almost negligible top positive. Okay, there is one study I'm not remembering. Okay, so even the pre-diabetics, so-called metabolic syndrome, also should be screened for diastolic dysfunction or heart failure, with a preserved LV function.
So sir, staying back to the same question, so how many patients you will put in a non-diabetic patient who are supposed to be so-called heart failure in the range on SGLT2 inhibitor as of now in your practice?
See, again, I'm telling you, these benefits are best found in diabetic heart failure patients. There is only one trial, that is HF, DAPA HF trial, and another is Imperial trials coming on, probably going to publish next month. That has shown some benefits. But as long as patient is diabetic and heart failure, straightway I will start the SGLT2 inhibitors, right? The preserve in non-diabetic, I will still hesitate to start as a primary drug. Okay, all the 4 drugs I utilize, then I may think of otherwise I don't.
Okay. So Sharad sir, are you there? One last question for you, and then probably we can. Sharad sir is there?
There is a lot of disturbance.
Okay, I think there are a lot of some network issue with Sharad.
Yes.
Yeah. So sir, hello, can you hear me?
Yes.
So once patient is on dialysis, I'm just asking both nephrologists. Once patient is on dialysis, how does your prescription look for a diabetes?
So, as I said in my talk, that your aim should be to give calories of 30 to 35 kilocalories per kg body weight per day. So if he's a 60 kg male, you give calories of 2000, proteins of around 72 to 75 grams. And for that calories and that proteins, whatever the sugar goes up, you can give insulin, you can continue with glycoside, and you can give DPP-4 inhibitors. Now, DPP-4 inhibitors, linagliptin, they say that you don't need to change the dose, but it is 42 rupees a tablet. We give linagliptin small dose, half the tablet or 1/4 tablet, and that helps to control the sugar, and the cost comes down. So these are the 3 drugs which we'll give to the patient: insulin, glycoside, and DPP-4 inhibitors.
Kulkarni sir, you want to add something?
Yeah. You can repeat the question. Sorry, Kapil, I missed that.
What management of diabetes in a patient on dialysis?
On
Dialysis.
dialysis. Yeah,
How-
yeah.
yeah. So
Yeah, I
what
think.
Arvind, what Arvind sir has said, he will use glycoside, he will use small dose of indagliptin, and obviously you differ or you stick to same.
Yeah, I think I would agree with him that insulin remains the most effective, safest. I think there is a role for DP4 inhibitors. Of course, vildagliptin is there, linagliptin is there. Linagliptin also is equally effective. Also, you have this choice of ripaglinide.
Ripaglinide is
Many of
actually
our
one good drug.
patients, yeah, many of our patients. I don't know what the opinion is, but that is a very short-acting, which can also help to avoid hypoglycemia and control the sugar. So I think
And
these choice.
GLP-1 analog are also on there.
Yeah, I think the recent, again, some of the studies with dulaglutide safety has been established in renal patients. So I think you'll have to be a little careful in using GLP-1RA for the fact that, a lot of side effects are there, GI especially, So I think but there is an indication. Yeah, I think that is one more drug which you can add.
Yeah, Arun Shah, sir, you are.
Yeah, so as I said, these dialysis patients, your HbA1c target should be higher, not 6.5. It should be around 7.5 range. Let the patient be slightly hyperglycemic. Let him eat very well. Those who don't eat well and keep their sugars under control, then they do very badly nutrition-wise, and they succumb to the on dialysis very quickly in a year or two. So their nutrition has to be very, very good. That is where we fail in our country, that patients continue pre-dialysis diet and nutrition and do not improve their nutritional intake on dialysis. So diabetic medicines you may have to increase slightly from your stage 5 CKD patients once you are on dialysis and when they start eating very well. But don't restrict the diet.
Okay, so I think
end up.
we should end it. One last question to because that is specifically come in the chat box. So Dr. Ratnaparki sir can answer this. So a lot of echo report will show grade 1 diastolic dysfunction. You treat them or you don't treat them? If yes, so SGLT2 are the answer for this diastolic dysfunction?
Grade 1 dysfunction should be treated non-medically, preferably. Okay, because grade 1 LV function is normal and there is a stiffness of the muscles basically. That we should be primarily treated with non-medical therapy, reduction in the weight, exercise, salt restriction, control of hypertension. All these secondary risk factor has to be controlled. And then only if patient is diabetic and all these things, then you can use drugs. Otherwise, non-medical therapy.
Okay. I think
Kapil, we have one more comment. I think the calcium channel blockers we talked about. So far, we thought the two calcium channels cannot be combined. But recently, the dipyramidal and non-dipyramidal groups can be combined in resistant hypertension. So you can combine diltiazem or verapamil like drugs in addition to our calcium channel patient who are resistant hypertension. That's one component came from Dr. Bakri's in recent his talk. And many of these trials have shown in the first choice given ACRB, the second should be calcium channel blocker. But many people in the trial of ALERT, the diuretic showed more benefit than even the calcium channel blocker in reduction in stroke. So I think, do you think the first is ACRB? What should be the next? Either diuretic like thiazide or it's a calcium channel blocker? Because those large trials are there with ALERT. Those metabolic side effects of the diuretics are considered. The insulin and the electrolyte imbalance and uric acid, everything. But the whole of mortality was reduction was better with the thiazide type of diuretic compared to calcium channel blocker. So what will be the Kulkarni Sahib talking of combination therapy? What should be the first choice after ACRB?
Yeah, I think that point was very well taken in that resistant hypertension paper which has just come. So I think because of the paucity of time, we need to conclude. And let me thank all the speakers and all the chairperson. Dr. Ponde sir has left, but my sincere thanks to him also and to all our panelists for that extremely wonderful session. And we have got a marathon session of 2 hours with more than 250 plus attendees having the benefit of the wisdom of all the experts. So on behalf of Andheri Parla Physician Association, I thank you, each one of you, for this wonderful talk, and also thank JB Chemical for giving this technical support and has been always ready for such kind of academic endeavor. I hand it over to JB Chemical guy, Milan or whatever.
Thank you, Dr. Kapil. Thank you very much, and thank you to all the speakers, especially like the session and the question and answers, which have been taken very in a very patient manner. So thank you all of the participants, and thank you again for participating in this session. Thank you so much.
Thank you.
Thank you.
Thank you so much.